Hello and welcome. Thank you so much for spending your evening with us tonight. We've got a really good session lined up. So this is part two of a paediatric series that we're having with the Werribee Mercy Hospital, and part two's all about atopy. The first session, if you missed that one, that was back in July, and it was on, excuse me, ADHD and ASD, and we did record that one. So there is still the opportunity to watch that if you're keen. And our third and final part of the series is lined up for September, and that's around gastrointestinal stuff, constipation, and non-IgE food allergy. So should be another really good session. So we'll let you know when that's available to register for that one as well. My name is Alison Burgess. I'm the manager of the primary healthcare team here at the Northwestern Melbourne PHN. So the role of my team is to support general practice with all of the work they're doing, and obviously we're providing a lot of support at the moment around COVID specifically, and you'll be getting a lot of support from our relationship managers, but also a big part of our team is to run education and workforce development sessions like we do, or support those sessions like we're doing tonight. So always keen to hear about what you're wanting or needing to learn about. Before we continue on, I'll just make sure my slides are going to progress. Let's see how we go here. There we go. I just want to make sure we take a moment to acknowledge the traditional owners of the land on which we're meeting, or maybe you're viewing from today, and pay our respects to their elders past, present, and emerging. A little bit of housekeeping that we always need to do with these webinars to make sure it runs as smoothly as possible. Everyone who's dialing in tonight, you're going to be on mute automatically, and you will be for most of the session, but we still really want you to interact with us, and we'd really love you to ask questions, because we find that we get some really good discussion happening when we do have more questions. So the way to do that, you'll have a toolbar. It normally sits on the right-hand side of your screen, and there's a question box. So you can actually type in the questions, and we'll answer those at certain points along in the session when we have scheduled breaks, or definitely at the end, and we'll get through as many as we can. So please put any questions you have in there. You'll also notice there's a chat box. So the chat box we actually like you to use if you're having any difficulties, so any sort of technical difficulties or those sorts of things that aren't sort of specific questions for the content of the session. We've got our program officer, Jen Francis, who's sitting behind the scenes, that will be able to chat you through any of that stuff in that section. So make sure you use either the question box or the chat box tonight. And as always with any education session we run, there'll be a post-course email that we'll send out. Usually tomorrow morning it will come out, and that will contain any additional resources or things that we've talked about tonight that we want to make sure we get out to you, plus additional links to other sessions we have coming up. And really importantly, we have the evaluation survey, which is asking a few questions about what you thought about the session, what was really useful, what wasn't, and obviously what you'd like to see in future sessions. So if you are able to take a few minutes to fill that in, we do really look at that quite closely to make sure our sessions are as most appropriate as possible. I think that's all the housekeeping. While I mentioned COVID before, and just with all our sessions, COVID being such a big issue for our catchment at the moment, just reminding you all working in general practice of the best ways to stay up to date with all the latest COVID information that's coming out. Obviously, the quick reference guides on the DHSS website. Really importantly, number two, if you're not already receiving the updates from the PHN, so these e-blasts that come out quite regularly, usually a couple of 2-3 times a week, that has really condensed information that's put together that's most appropriate and most relevant to general practice. So it's a really good one-stop shop for the real latest updates and all the changes that are happening really quickly. So if you're not receiving those already, please respond to the email that you receive tomorrow, and we can make sure you get signed up to those. Obviously, health officer alerts, you've got the hotline number that's been around for a while. And lastly, don't forget that Health Pathways actually has COVID specific pages that have been developed and are constantly being updated as well. So another great resource if you're really looking for COVID specific information, and particularly on the new COVID model that's being piloted in our region as well. There's brand new pathways specifically around that model, and some of you joining us tonight might already be part of that model that's happening. So again, have a look for those. Other things, while I've got you captive to look at a few different things, other upcoming education training sessions that you might be keen on attending. As I said, there's part 3 of this in September, but probably 2 that I want to point your attention towards tonight. Actually next week, so we've got the the PQI practice reports, which will be coming to your practices in the next week or so, and we've actually got an education session that's talking through what those reports are and how you can use them for quality improvement in your practice. You'll also have contact from your relationship managers, but that's the first of 2 sessions. So have a look at that one if you're keen on looking at those sort of things. And the other one is the National Immunisation Program Update session. So that's happening on the 20th of August. There's been quite a few significant changes in that area recently, which might have gone a little bit unnoticed or maybe not quite as understood because of the COVID situation. So it's a great opportunity to really brush up on what were the specific changes that have happened in that area. And these are obviously all webinars as well. And these are all on our website. So if you want to register for any of those, that's just jump on there and do that, and we'll put those links into the email as well. We have the PHN think tank, so we're always trying to recruit for our think tank any health professionals that work in our catchment. We're regularly reaching out to health professionals, or particularly those in primary care, that you might be keen in a particular area or a particular clinical area, or we might reach out to you in terms of reviewing some resources, be part of planning groups, review groups, actually to do facilitating education, or all kinds of things which sometimes we're able to remunerate you for. So what the think tank is if you register for this, you're actually registering to be part of a group that receives these opportunities. So you're not actually signing up specifically for anything yet. It's just to hear about the opportunities that if there's anything that sparks your interest, you can put your hand up and go, yep, I'd like to do that particular opportunity, and then we can get you involved. So yeah, if you'd like to be more involved in some of the work we do at the PHN across the region, we'd love to have you part of the team, whether that's a GP or if you're a practice nurse, practice managers, part of the practice admin team even. You've all got different skills and expertise that we'd love to reach out to sometime. So again, think about joining our think tank. Another opportunity that's just opened up, this is specifically for the Hume area, but there's a good chance that we'll actually open this up to practices outside of the Hume LGA region, but we're offering opportunity to do a quality improvement project in diabetes where you work closely for a period of time with one of our relationship managers to run quality improvement activities related to diabetes in your practice, and this counts towards your quality improvement PIP payment requirements as well, so that ticks you off for there. So if you're keen, let us know, we can give you more information. And a reminder that Health Pathways is always available, and there are some really good specific pathways in the paediatric space, and these have been updated really recently. They're obviously regularly reviewed and updated, but really recently they've gone a good overhaul to be much more specific. So again, we'll provide that information in the follow-up email, but just making you aware that they're available. So that's enough of me talking and taking up too much time. We're going to get to the good stuff now. So I just want to quickly introduce our speakers and thank them for their time tonight. So we've got 2 presenters. So Dr. Karen, I was going to say that. It's going to go Dr. Karen, sorry, from Werribee Mercy Hospital. So Karen is a general paediatrician and also works at the Victorian Forensic Paediatric Medical Service. She has a special interest in the management of acute childhood illness and the assessment of children who have suffered abuse or neglect. And then we're passing over to Dr. Dan Mason, also from Werribee, paediatrician with an interest in general paediatrics, neonatal medicine and refugee health, and has recently commenced consulting at Utopia, Refugee and Asylum, Seeker Health and Hoppers Crossing, which is really cool. So I'm going to hand over now to Dr. Karen. So we'll just hand over the screens there and we'll get going.
Oh. Hi everybody, I'm Karen. Just give me 2 seconds because my photo took up most of the screen. All right, so I'm talking about asthma and allergic rhinitis tonight. These are the topics that I'm going to be covering during this talk. And I guess asthma is quite a common illness. It's frequently seen in children. It's a common cause for hospital presentations, and why we thought it would be a good topic to discuss tonight. I thought I'd start off by talking a little bit about asthma and bronchiolitis and why we don't treat them the same way, and they're different disease entities. So asthma is a chronic inflammatory disease characterized by reversible airway obstruction and bronchospasm. It's usually diagnosed in children over 2 years of age, but we know that children under 2 can certainly have reversible airway disease as well. The exacerbations in asthma occur when allergens enter the airways from multiple different triggers and cause inflammation in the airway walls and tightening of smooth muscle. We then deliver medication which can relax the bronchospasm and relieve the symptoms. This is in contrast to bronchiolitis, which is a viral lower respiratory tract infection, which causes inflammation of the respiratory tree, particularly the bronchioles. It's usually in children less than 12 months of age, diagnosed on history and examination, and we don't use any investigations to diagnose it, and that it's a self-limiting condition. Care is supportive and no medication has been shown to be effective to reverse this airways disease. We're going to walk through the management of a patient with asthma, and this is a 6-year-old girl called Lucy who presents to your practice after having 3 days of a runny nose and a cough and a wheeze since the night prior to presenting. Her parents gave her 6 puffs of Ventolin before she went to bed because they're familiar with her having asthma, and she had 2 lots of Ventolin throughout the night, but she was still short of breath, so they came into practice in the morning. So when a patient presents with asthma, it's important to go through their history. How long have they been unwell? What happened when they first became unwell? And what's been the progression? Are they using more Ventolin? Have they used any Ventolin? And how's it being delivered? Are they delivering it appropriate for the age of the child? Are they using the mask in the spacer, or do they have a nebulizer at home? If you can, talk about the triggers with the parents. Does the child have a virus? Have they been exposed to any particular allergens? And then go through any possible interval symptoms such as nocturnal cough and exercise intolerance the child may have had leading up to this acute exacerbation. In Lucy's case, we know that she's been unwell for 24 hours with shortness of breath and cough, but she had a runny nose prior, and so the trigger is probably a viral infection. She's had 6 puffs of Ventolin 3 times in that 24 hours prior to presenting to you, which is not a lot of treatment for a child of her age, and they certainly could have used some more. The possible triggers that you need to ask about include viral infections, which is the most common cause of asthma exacerbations in children, exercise, which we tend to see more frequently in older children, rapid changes in weather, particularly thunderstorms, and then allergens and irritants. Asking about past history, go through their birth history, question about prematurity and previous chronic lung disease. Ask about other features of atopy, so eczema, hay fever, allergies and anaphylaxis. It's important to ask about school attendance and if that's been affected, whether or not the child is able to participate in all the activities they'd like to and what their sleep is like. We should be able to control asthma now so that children can participate in any activity that they would like to do. And generally, parents can provide you with a pattern of illness. Ask about the family history, if there's a history of atopy and if there's a history of smoking. We find out from Lucy's parents that she was a term baby and that her asthma was diagnosed when she was 3 years old. She's had 3 hospital admissions every winter since she was diagnosed, and in the last 2 years, she's been to intensive care twice. She's had 6 asthma exacerbations each winter, and all of them have been secondary to a viral infection, but thankfully she doesn't have interval symptoms and recovers very well between exacerbations. She did miss 3 weeks of school last year in prep, and there seems to be a pattern of her developing asthma only over the autumn-winter seasons. She doesn't have any other features of atopy. Both her parents had asthma as children. Then you come on to your examination. The child's general appearance and their work of breathing are the most important signs about how this child is coping with their airways disease. Wheeze has been shown to be a poor marker of severity, and auscultation can sometimes be limited to patchy changes and difficult to interpret. I wanted to just mention at this point that we're not doing throat examinations at the moment due to COVID. Normally when we do our respiratory examinations, we would look in a child's throat, and we are unfortunately still seeing some children presenting to the hospital who have had throat examinations, but it's generally been released that that's not safe during COVID. And always beware of the child with a silent chest. We tend to see these more in adolescents where they're masking their symptoms quite well, but when you listen, you can't hear much air entry at all because these children are quite sick. When you look at Lucy, she's bright, she's got coryza and a dry cough. She's speaking to you in short sentences and she appears to have mild to moderate work of breathing. And as we typically see on auscultation, she's got widespread wheeze. Then you come to considering treatment options. And generally speaking, at this point, I turn to Ventolin. It's a well-known medication that parents have often heard of and they're quite comfortable with. Some of you might have it with masks and spacers in your practice, and some of you may have nebulizers. Studies have shown that neither one is more effective than the other, but we try and get people using the masks and spacers as soon as we can because they're portable and they can carry them with them everywhere they go, including to school. If you are using nebulizers, it's important to remember that a 2.5 milligram nebula is equivalent to 6 puffs and 5 milligrams to 12. So if you've only got the 5 milligrams in a small child, you can accumulate Ventolin quite quickly. And again, I just mentioned here that during COVID, we're trying to avoid all nebulized therapies. So again, make sure you're safe. It's at this point in the consultation that I like to explain to parents why we're using the mask and spacer to deliver Ventolin. I usually explain to them that the airway is like an upside down tree, with the throat being the trunk, and as you go further out towards the leaves, the branches get smaller, just like in the lungs, how the airways get smaller and smaller. And what we need the child to do is breathe the Ventolin in right to the end of those small airways. And that this is quite hard to coordinate, which is why we use the mask and spacer for the smaller children and continue to use the spacer as children grow up and into adulthood. Once they can get the Ventolin into those smaller airways, the smooth muscle can relax and their breathing will improve. If, of course, they get a little bit too much Ventolin, you'll start seeing multiple side effects, which hopefully they'll avoid. But it's important to remember that Ventolin saves lives and that once you're getting these side effects, you're obviously quite worried and calling an ambulance or asking for extra help is important. Steroids has become quite a controversial point in paediatric asthma over the years. I thought this quote summarised it up quite well. When I started paediatrics, we used to give every child, regardless of severity, 3 days of steroids as soon as they came into the practice. But in 2009, around this time, a few studies came out which showed that actually in the preschoolers, it wasn't that effective or creating that much change. And since then, we've been much more cautious with prescribing steroids to that age group. Generally speaking, I use the marker of if the child is being admitted to hospital. So if they're coming into hospital, then I tend to give them steroids. I give them 2 milligrams per kilo for the first day and 1 milligram per kilo for the next 2 days. I remind the parents it takes 4 hours for this to help with treatment, and this does cause a resolution in some symptoms and decrease the rate of relapse in a current episode. And generally, there will be some patients that you will still want to use steroids for in the less than 4s, but most of the time now, we're using steroids in school-age children and above. But then there's Lucy, who's known to have a history of quite significant and severe asthma. I'd give her the 6 puffs of Ventolin and then reassess how she's going. If you can observe her for a short period, I would, because we don't want her to deteriorate. And given her history, I actually would give her steroids to go home with. And I'd be thinking with Lucy about all these exacerbations that she's had and whether or not she needs a preventer. Preventers are not that commonly used in paediatrics. Only 5% of children will actually need a preventer. They do help reduce impairment and reduce risk. And I explain that to the parents when I'm giving to them, that we use them in 2 types of children. The children who have interval symptoms, the nighttime cough, the difficulty with exercising, and the children who often get exacerbations either needing hospitalisation or needing prednisolone. These are the questions I usually ask when I'm assessing the need for a preventer. And I often get parents to document these onto a calendar for a while before we decide to use them, especially if I haven't known the patient for very long. So how frequently they use Ventolin or steroids and the interval symptoms that they're having. So if they're, often parents will say to you, we use Ventolin all the time, but when you question them further, that all the time is once a week or once every 2 weeks. Having them document that on a calendar helps you and them see exactly what you're seeing, how much they're using. Also, if they can document the triggers, that's very helpful to find out if you can get rid of those triggers, but for them to see as well. Remember, if you're starting a preventer, that they take up to 6 weeks before you see a positive effect. There's been some studies to look at whether or not using a preventer infrequently or just during an acute illness is helpful, but as far as I'm aware, up until now, we haven't had any definitive evidence that that is a good thing to do. So working in paediatrics, I like to keep things very simple, and Flixitide is my preventer of choice to start with. You use it in half the dose that you need of Pulmicort, and the studies have suggested that it's more favourable and the safety profile is exactly the same. So I use Flixitide for all of my patients that need preventers. The local side effects of oral thrush and hoarseness we're used to telling people about. I often tell people to keep their preventer next to their toothbrush so that they have their preventer and then brush their teeth. And there's a lot of steroid phobia out in the community with concern about systemic absorption. Hopefully you'll be able to use the preventer in such low doses that this won't be a problem. There's no convincing evidence that doses of less than 400 micrograms per day are associated with growth suppression. And usually we get away with up to 200 of Flixitide. If you're not quite getting there with just the Flixitide, the next step is to add on a long-acting beta-2 agonist. Now, these have only been shown to be effective if they're used in conjunction with an inhaled corticosteroid. And they can be useful if you've got persistent interval symptoms. But generally, we try and get them on and off quite quickly. These are the side effects, which can be quite significant in some children. And I always explain these to the parents so they understand why we want to use this medication regularly and properly so that we can get rid of it quickly. If I'm adding one, personally, I tend to use Seretide because you're keeping a consistent medication and only adding one adjunct so you can see what's going on. I usually start my preventers of Flixitide 50 mics twice daily. If it has to be just once a day, it's 100 mics once daily. And once I'm getting up to 100 mics twice daily, that's when I start thinking about adding your long-acting beta-2 agonist. Singulair is an interesting drug that's come onto the market for use in our smaller children. I tend to reserve this for children who have lots of allergic qualities, so your atopic children. It's a chewable tablet, so some kids find it easy to use, and for some, you get quite good improvement in your mild to moderate asthma. So a summary of what I do. In acute asthma, I use Ventolin. I give prednisolone, but I do try and avoid it in year less than 4 years. And if I need a preventer, I start with Flixitide, move on to Seretide, and keep my Singulair for the allergic type children. So in Lucy, I would start her on Flixitide 50 mics twice a day, and I'd be aiming to use it from May to August. It was the beginning of May now when we're seeing her, so hopefully by the time this kicks in 6 weeks' time, we're into winter and we might be able to have less severe exacerbations this year, keeping her out of hospital and hopefully keeping her out of ICU. I make sure she has an up-to-date asthma action plan. There's multiple of them around. This is the one from the National Asthma Council. I tend to use the one from the Royal Children's Hospital Clinical Practice Guideline, but that's because that's the one I'm used to. Neither one is right or wrong. It's just important that they have one. We also have a great community asthma program in the Western region. They've been picking up patients really quickly for us and a great support to parents and education for schools as well. I find that in patients like Lucy, where they should be quite familiar with asthma management given how unwell she is, people from the community asthma program will go into the home and talk to them about asthma and often fine-tune their management and get them actively involved in life with less exacerbations. I thought it probably fit well here to just have a quick chat about a chronic cough, because coughs are really common in children and post-viral coughs can last up to 6 weeks. And when you consider that kids can get 6 to 12 viral infections, especially in the toddler age group, you can have a cough for most of winter and that be completely normal. And we often hear the 3-year-old that's come in coughing all of winter. And once you explain to parents how many infections children can get in a year, they're more understanding of what's happening. In my mind, I break these children with ongoing coughs into 4 different groups. And this is on the Royal Children's Hospital chronic cough guideline as well. But this helps me work out in my history to make sure that I'm targeting with the right questions. These are the red flags I have in my mind, that once the cough has been going on for 4 weeks, I really need to know that there's been other viral infections along the way or that things are improving. Productive coughs are uncommon. So if the cough is actually productive, this may be one that needs a little bit more of a look in and possibly some antibiotics. If a child is well, thriving, developmentally normal, it's unlikely that there's something significant wrong. So if any of these other features are present, then that's definitely a reason for referral. So with chronic coughs, productive coughs are uncommon. And if they're going on for more than 4 weeks and not getting better, it's reasonable to get a chest x-ray and refer them to your local paediatric or respiratory paediatric service. If you can, try and avoid Flixitide and long courses of antibiotics in well children. Ask parents to keep a diary of when the child's coughing and see if you can work out if there's another trigger for that cough. At this point, does anybody have any questions? All right, then.
Sorry, just getting myself off mute. No, not as yet. So just remember you can use the question box. If you just type those in there and we'll keep note of those. So even if you have them later on, we can bring them up at the end of the session on this topic. Yeah.
Once I prepared this talk, I was thinking one question we often get asked about with asthma is at what age do you first trial Ventolin in a child? In a child with a significant history of atopy, I will consider trialling Ventolin from about 10 months onwards, keeping in mind in these small children that sometimes if you just give them 6 puffs with the mask and spacer, they cry and cough, they clear secretions and appear to have a clinical response, but it's really about what happens the next few times. But certainly worth trying from 12 months on in most children that present with wheeze. All right, moving on to allergic rhinitis. So allergic rhinitis is one of my favourite conditions to treat. It's a condition that when you treat it, you can make a significant improvement to children's lives, and people often don't give it the merit and are really surprised when they have such an amazing improvement in their life. So I've listed the common symptoms down. I always ask the parents, how many pillows does your child sleep on? Are they always rubbing their nose with their finger? Are you always telling them to get a tissue? Because they're the symptoms that they don't realise that they're just treating without thinking. I tend to group allergic rhinitis into 2 groups. So the seasonals and the all year round. The seasonals tend to be responding to grass and tree pollens, and the kids with the all year round allergies, they're usually your dust mites and your animals, and things like that. Allergic rhinitis can produce lots of symptoms that are underappreciated: sleep disturbance, daytime tiredness, headaches, poor concentrations, ear infections, and definitely children who have poorly controlled hay fever will have poorly controlled asthma. Once their hay fever is treated, their asthma control improves significantly and their risk of fatal anaphylaxis goes down significantly as well. These conditions are so interconnected. To get parents on board, I often talk to them about how your child will be underperforming at school and not reaching their greatest potential. And that usually helps them come on board with the importance of treating this condition. Allergy testing is always brought up in these consults, and really allergy testing hasn't yet been perfected. Skin prick testing is only available through allergists, and we do have options to do blood tests, but they don't tell us an awful lot often. I sometimes use them when I'm trying to work out if this is an allergic blocked nose or an obstructive blocked nose. Sometimes when I'm trying to prove to an ENT that we've tried a treatment and it's not allergic, and then I do some allergy tests so that I can say, see, and these are normal too. And also with the blood tests, it's fine to do things like grasses and mixture without specific grasses, because in most cases the treatment would be the same. One of the ones that's really good to work on is your house dust mite. So allergen minimisation for kids with allergic rhinitis is really important. And I love these information sheets because they tell you how to minimise exposure and things that parents often don't think about, like washing the bedding in hot water and hanging it inside so you don't collect the dust from outside. And this RCH information sheet is particularly good because down the bottom here, which I've tried to highlight in purple, are 2 brands of safeguards which actually have evidence to show that they improve symptoms. And I've had children say to me, just by using these pillow guards, because they are quite expensive, but just using the pillow guard and not the quill protector has actually improved their symptoms. So there's lots of things that you can do for allergen minimisation. Management strategies, we've got our oral medications, the antihistamines, and really cetirizine is our medication of choice in paediatrics. We've got most of the evidence for that one. And there's eye drops, but really the mainstay of treatment is nose spray. They all say on the bottom that they're not licensed for children, but indeed we use them for children all the time. And the main reason that nose sprays fail is because of lack of compliance. So it's important to explain to parents that when you are giving nose spray to your child, that you're aiming the nose spray towards the ear of the nostril that you're spraying into. A good way to achieve that is by holding the nose spray with the opposite hand to the nostril and then spraying it towards the ear. And I always show them a picture so they understand that we're not trying to treat the septum, we're trying to treat the membranes along the outside of the nose. Usually I'd start with Nasonex, 1 spray in each nostril twice a day for a week or 2, and then move on to daily for up to 6 weeks and then assess where we're at. At that point, you can either stop and see how the child goes, or if the child's having such amazing improvement, you can continue. Avamys is usually my next go-to agent. Now, these are the same agent essentially, but Avamys is a gentler spray and tends to be better tolerated by adolescents. The catch is it's more expensive. I always give them an allergic rhinitis plan off the Askia website, and it shows this nice picture down the bottom of not spraying into the septum and helps people realise it's a real condition. I also get them to download a pollen app, and so that way they can pre-medicate with some cetirizine before they go out in a day on high pollen days if pollen is one of their triggers. Parents often ask about desensitization, and I always say it's for older children, and the kids need to buy into this. It's lots of needles, has to be done through the allergy service, and takes a long time. Unfortunately, desensitization often has some hiccups along the way, and it goes for much longer than is expected. But definitely something to consider once the kids are older. And that is all from me tonight. If nobody has any questions, then I can hand over to Dan.
Just looking at the questions here. Question from Amy, what about oral Densin?
I am not familiar with that. What's its what?
Densin?
Maybe desensitization.
Desen, sorry. Just clarified, yeah.
For allergens, is that what? Is possibly what's me?
So yes, yeah.
Yeah. So when I was working the allergy clinic at RCH, we weren't doing oral desensitizations for much at all. There is a different antibiotic clinic that was doing some, but as far as other allergens, we weren't doing any. I'm not sure if that answers your question. So all the desensitization was done with needles.
Okay, yeah, I think you might have answered that question for her. And just a general question, is there anything in particular regarding the topics you've just talked about that they should be considering that could be confused for asthma or COVID or vice versa? So anything in the COVID space that they need to be particularly aware of that you've come across?
I think that you should consider that every patient that presents to your rooms at the moment with asthma has COVID, and similarly if you've got symptoms of allergic rhinitis. So we're considering any patient that presents with anything infective at the moment, aside from things like, you know, maybe cellulitis or things like that, to be possible COVID. So that's what we're doing in the hospital space, and I think that's what you need to be doing as well. I mean, asthma is triggered usually by a virus. Kids are presenting with atypical COVID features. So if they present with diarrhea, we're calling them possible COVID. Rashes, unless it's, you know, something really familiar, like eczema, we're considering all of these kids to be COVID and using full PPE to assess them.
Great, so that's all the questions we have for now. So we can probably, move on to Dan if that's what we like to do. We can always, again, take more questions at the end if you do happen to think of any.
Great.
Just type them in the box. Thanks.
Hello, everyone. Sorry, I'm just trying to share my screen. Can I just clarify that you can see my screen there?
Yeah, yep, got your slides up now.
Great.
Perfect.
Thank you. Thanks, everyone. So my name's Dan. I'm another general paediatrician at Werribee Mercy. I work with Karen, and today I'm going to talk about eczema and particularly, I guess, aspects of the presentation and the management. In terms of the outline of the talk, I'll be talking about everyday management of eczema, having a discussion about flare management of eczema, some common complications of eczema, a little bit of a comment about food allergies, because I know this is something that often comes up in primary healthcare and with us as well as paediatricians. And then just a few, I guess, tips and tricks about common eczema management misconceptions. And this is from one of the eczema nurse specialists from the Royal Children's. And so, you know, I'm very cognizant of the fact that there's a big group of GPs here with a lot of experience in managing eczema, and the collective expertise is high. So I hope that this can be of some benefit in certain aspects. So just very quickly, I think we all know a bit about eczema from a background point of view. It's a chronic inflammatory skin rash. It's got a very high prevalence in children, you know, up to 30%. And the majority of these kids will grow out of their eczema, more than 50%, you know, by their kind of later childhood years. And it's really important to remember that early treatment and good early effective treatment can actually lead to early cessation of eczema. We try to characterize the treatment of eczema into the baseline treatment, escalation of management for the treatment of flare-ups, and then being aware of chronic changes that can occur, including thickening of the skin and lichenification. We also talk about this atopic march, and a little bit on what Karen said was that, you know, there are some people who have higher levels of IgE, which can predispose them to atopic disease. And we see this often manifest as eczema in the early years of life, progressing through to things like bronchiolitis, viral-induced wheeze, asthma, and also food allergies and other allergies. And so it's important to identify this early on. There's often a family history of atopic disease as well. The other thing I would say is that the kind of morbidity for eczema is very high. It can certainly cause a lot of pruritus and itching, which can affect sleep. And similar to what Karen was talking about with allergic rhinitis, it can affect children's ability to function well, things like school and behaviour and things like that. The diagnosis is made primarily on a clinical basis. We don't usually need to do any formal testing. So the presence of itchy skin with more than 2 of either a dry skin red or rough skin, an atopic history, so either in that child themselves or in a first-degree relative, with a typical age of onset, which is usually less than 2 years of age, and a typical distribution, which can vary with age, and there are some variants. We tend to see, from a distribution point of view, you can see on the left there a younger child or an infant with more widespread truncal eczema, whereas in older kids, eczema seems to be more apparent in the flexures, so particularly of the arms and of the legs. And you can see on the far right, there's evidence of some thickening of the skin, which we would say is lichenification. There's a few red flags, I guess, to consider when you're seeing kids with chronic skin rashes in the early years of life, to make sure you're not missing other important diagnoses, which are rare, but certainly can occur. So things like poor growth, so a child who is dropping centiles or not putting or losing weight, a child who's having persistent significant infections in association with the skin rash, and also children with chronic diarrhea and a skin rash as well. And there are some rare conditions where you get eczema with immunodeficiencies, so things like a severe combined immunodeficiency can present with a prolonged rash, and some very rare syndromes as well, where eczema is a component and an immunodeficiency is a component. So these are rare causes, but worth keeping in the back of your mind if you're thinking this is not a typical young child presenting with eczema. So I wanted to just go through a bit of a case study and work through some of the management, I guess, discussions on the basis of this case study. So this is a 9-month-old boy who presents to you with an itchy red rash. He has red cheeks, abdomen and upper arms. As you can see on the pictures there, it's quite widespread over his truncal area and particularly on his cheeks. On history, it tends to be worse after baths in winter, worse with woolly jumpers. He's an otherwise thriving boy who's putting on weight and developing appropriately. And there's a family history of eczema in the father that has subsequently resolved, and some mild asthma that is persisting. So my approach to a patient like this would be to say, first of all, we need to think about the everyday management of this child. Then we need to have a plan for an eczema flare, so when this child's eczema exacerbates, and then have a think about what are some of the complications that might occur and have a plan for managing those complications. So the everyday management for infantile eczema, so and particularly if it is mild without evidence of a secondary infection, much like our case, everyday management really involves avoiding triggers, and in this child on the history you've identified that one of the main triggers is heat and clothing, so that big warm woolly jumper causing sweating underneath and not allowing the skin to breathe. We want to make sure we're hydrating the skin well, and so that requires the use of moisturizers, bathing every day and making sure that the bath is not too hot, as that can sometimes exacerbate, and using, as I mentioned, moisturizers or emollients. And so you can use these common moisturizers such as QV or Dermis or Sorboline at least twice a day as baseline treatment for mild eczema, and then having a plan for the management of flares. So in this child, it would be really about avoiding triggers, using moisturizers regularly, and making sure this child is bathing regularly. Common triggers that we see generally in eczema include heat, and so, as I've mentioned, baths that are too hot, kids who are wearing multiple or heavy clothing, and really important to try and encourage well-breathing materials and sheets, so particularly, good quality cotton can really make a difference. Dry skin, so trying to avoid alcohol-based wipes, and always using bath oil in every bath to try and help rehydrate the skin. And trying to avoid irritants, and these irritants can be different for every child, but common ones include things like detergents, soaps, perfumes, prickly fabrics, even things like long nails that can exacerbate that pruritus and itching. And I've got infection here, and so one of the reasons for daily bathing is to try and generally reduce your bacterial kind of load on the skin to reduce that risk of secondary infections. Obviously with, I guess, particularly more severe eczema, when there is skin breakdown, there's a very high risk of your normal skin flora causing infections that need to be treated on the skin, and that's a common complication that we'll talk about a bit later. So continuing the case study, so you manage this boy well with your regular moisturiser and advice. He has a good few months that he represents to you 3 months later at 12 months of age. His mum has returned to work and it's been a busy time for the family. She says it's been quite difficult keeping up with that regular regime, and he presents with a 1 to 2 week history of worsening truncal and flexural and facial eczema. At this point, he's sleeping poorly. He seems to be a bit unsettled overnight, but otherwise he's still thriving and growing and putting on weight beautifully. So this is the way he presents, and so you can see he's got quite significant erythema and what looks like pruritus on his cheek and over his trunk, and you can see him scratching there. This is not actually his leg, it's an older child, but you can see significant erythema, some breakdown of the skin, and also this kind of whitening and thickening of the skin on the leg and this is a sign of kind of more severe eczema and more chronic changes. So this child is now having a flare. You've had your baseline treatment, and despite this, the child's had a 1 to 2 week history of worsening symptoms. So you need to escalate your treatment accordingly. So at this stage, we would recommend increasing the moisturisers at least to 4 times a day, and recommending a steroid treatment. So this can be either daily or twice daily until the skin is clear. And we really recommend applying this underneath the moisturisers. So it's really important to make sure when you're adding steroids in that you're still maintaining your regular moisturisers. As you will know, there are different strength steroids, and we recommend different strength steroids depending on the part of the body. So on the face, we prefer to use as a first line lower potency steroids. So hydrocortisone 1% would be our first line therapy. If that's not sufficient, then you can increase to the stronger steroids such as Advantin, 0.1%, or Elidel, which is actually a non-steroid cream. It's really important though that if you're doing this, you set a few time limits on how long that you'll do it for. So Advantin really should only be used on the face in the short term, so for a matter of days, whereas Elidel you can use up to a few weeks on the face. And so if you're not having success with hydrocortisone, they would be the next 2 options. For the body, we're happier to use higher potency steroids. So we would recommend Advantin or Elicon or Diprosone. And that's generally because it's more well tolerated on the skin of the body. So important to have moisturizers up to at least 4 times a day, steroids daily or twice daily, and try to make sure you're using the appropriate steroids on the appropriate parts of the body. The other things that we'd recommend in this case or in similar cases would be consideration of wet dressings. And we'd say this 1 to 4 times a day for a minimum of 3 days. And I've got a link at the end of the talk to the Royal Children's Guideline about how you specifically do this. But essentially a wet dressing is a way to provide ongoing and significant moisture to the skin. And so after a bath with oil, you would put on your usual creams and emollients, so your moisturizers, so your steroids first, then your moisturizers, and then we would usually recommend wetting some paper towel and really wrapping it up over the affected areas and then putting bandages around that. And so it's a way to try and maintain hydration of the skin. If you can't use paper towels and bandages, even something like a wet t-shirt that a child can have on, or cold wet compresses for the face can be really helpful as well. Bleach baths, this sounds a bit dramatic and it can also sound a bit counterintuitive, but we often recommend bleach baths as well during acute flares. And what a bleach bath is, it's water that you add in a very small amount of bleach and oil and salt. And this is really based around trying to reduce the bacterial load of the skin. And again, there'll be a link at the end for the exact ingredients, but it's a very small amount of bleach. And so certainly for kids who are admitted on the ward, particularly with infected eczema, but also kids with severe eczema. For inpatient management, we would be doing these things every day. We'd recommend early review for a patient like this to see how they are progressing. And I think it's important to remember that these are really labour-intensive therapies, and every family will have a different capacity to be able to provide these therapies appropriately. So keep that in mind, I guess, when offering the therapies. So, continuing the case study, you treat this flare as we have. He has a good few months on baseline treatment, and he represents to you another 3 months later with ongoing worsening facial eczema that appears wet and weepy. And this has been despite 3 days of steroids and wet dressings and that flare treatment. He's afebrile, a bit grizzly, but is otherwise eating and drinking well. And so you look at his face and this is what you see. And so you can see here, obviously a very unhappy child, but very red, itchy looking face with these kind of dried, crusted golden crusts. And this is a very common, I guess, typical presentation of a bacterial secondary infection. So this is most commonly staph, and certainly need to consider whether this is a MSSA or an MRSA. And MRSA we do see much more commonly in children of certain backgrounds, particularly Indigenous children and children of Pacific Islander background. And I know around Werribee and around the hospital we do have quite large populations of children from Islander backgrounds. So consider MRSA in this case. The management of this would be antibiotics. Usually what we would recommend is soaking and removing the crusts, continuing the topical treatments, but really importantly needing to remove those crusts before you put the topical treatments on. Oral antibiotics will usually be appropriate unless the child is systemically unwell. And if you're seeing that this is recurrent, we can consider staph eradication treatment, which is essentially antibiotics. There's a regime of antibiotics and a chlorhexidine wash that the whole family has. And again, it's quite labour intensive, but we do this not infrequently in kids who present with recurrent boils for MRSA and recurrent infected eczema with MRSA infection. Some of the other differentials for, I guess, a complicated infected skin infection are things like eczema herpeticum, which we can treat with acyclovir if we treat it within a certain time frame, ensuring that we also get ophthalmology to make sure the eyes aren't involved. And some other more, I guess, rarer complications are eczema associated with Coxsackie virus, so eczema coxsackium. It may also be molluscum or varicella within an eczema lesion. So this is just another picture here. This is a typical presentation of eczema herpeticum. You can see these kind of these vesicles, particularly in the perioral region, and extending up in the areas around the eyes, in the trigeminal nerve regions. And this we worry about because kids can certainly get herpetic lesions in the eyes. And so we would usually get an ophthalmologist to review if it looks like there's any lesions around the eyes. And this is the more rarer eczema herpeticum, eczema coxsackium, which is this kind of vesicobullous eruption, and it's thought to look a little bit like an atypical hand, foot, and mouth type lesion in amongst eczema. So I think there's a few things that every patient with eczema should have, and the first thing I'll say is education, 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 and working on the front line. You all know this, but really a lot of eczema management is about understanding the pathophysiology and avoiding irritants, ensuring that there's frequent management of the skin hydration, even when the skin looks good. And I would say consider an eczema nurse appointment. So we have a great resource at the Royal Children's, which is an eczema nurse specialist, and they do have clinics where parents and kids will get, I think it's about 45 minutes to an hour with an eczema nurse, where they go through a lot of the aspects of eczema education and management. I would encourage them to have an eczema management plan. And again, there's a link to the Royal Children's website at the end of this talk, but similar to the asthma management plans. It's something that you can access via the Royal Children's Hospital Clinical Practice Guidelines, and it allows you to put in the child's name, their baseline treatment for flares, and other important information. It's a way of customising a treatment plan for a child. And I think access to additional eczema resources, so particularly some of the online resources, is really important. I just would mention as well that that we do have an eczema nurse who does work privately in the west of Melbourne, in Laverton, and I've got those details at the end. So for families who can afford it, I think it's about $100 for a first up appointment, 45 minutes with an eczema nurse, and I've got those details at the end of the talk. When to refer these patients on, we would recommend referring on kids who have persistent moderate to severe eczema despite adequate treatment and compliance, or moderate to severe eczema in those under 12 months of age, those with poor feeding, sleeping, or failure to thrive as a result of their eczema. And again, thinking about whether these could be some red flags for other conditions, and those with any suspicion of concurrent severe allergies, particularly recurrent urticaria, flushing, or anaphylaxis. In terms of inpatient management for eczema, we do, as paediatricians, see or have kids admitted for management of eczema, and I think some of the indications for this would be a child who's got infected eczema, who's unwell and febrile, and you're concerned about systemic involvement. Children with severe eczema flare management who require education for this management. So as we mentioned before, it's very labour intensive. Some of the things that we ask parents to do, and particularly if there are lots of kids and they're not able to provide that at home, and admission can sometimes be a really good way to nip it in the bud and increase the capacity of the family to perform some of these interventions at home. Yeah, I've gone through that. And what about food allergies? I just wanted to make a bit of a comment about food allergies. It's often discussed, food allergies in association with eczema. What I will say is there's certainly a higher prevalence of food allergies in people with eczema. It's up to about 20 to 30%. It's important to remember that food allergy doesn't cause the eczema. So the cause of the eczema is the atopic component of that person. Food allergies can sometimes be a precipitant or a trigger for an eczema exacerbation. The chance of having food allergies contributing is more likely in infants, so those less than 12 months, and if there's a family history of food allergies. And importantly, the diagnosis is really by exclusion diet, and we would only recommend this if this is a child who's failed intensive treatment in a high-risk group and there's been some liaison with an allergist or an immunologist. I think it's really important, and I totally appreciate that there are lots of families who will try excluding foods before they present to the doctor, but it's really important to do it in a sequential fashion, so you know that if you're excluding a food, it's actually having an effect, rather than going back and forth with multiple foods excluded and not knowing what one is actually having an impact. So I just wanted to kind of finish up with some common eczema management misconceptions, and this is directly from an eczema treatment nurse, and common things that they see in their clinics that they're helping to optimise. The first one is the idea that baths and showers dry out the skin. So as we've mentioned, if the baths are too hot, that can sometimes be detrimental, but really having regular baths and showers, particularly with oil, is a great way to hydrate the skin. And we know that dryness of the skin is one of the key exacerbators for eczema. The second misconception is that topical steroids should be applied sparingly. So there's certainly great encouragement for using topical steroids generously. The risk of side effects from the steroids is really quite low if they're used appropriately. Sometimes this can mean using, in kids with severe eczema, using almost up to one whole tube every day or two, but they should be used really generously. The third misconception is that topical steroids shouldn't be used on broken or open skin, and really important that you keep using the steroids, even for those who have a secondary bacterial infection with crusting. Soak the crusts, remove the crusts. If you've got open weeping skin, put the steroid directly on, and then use your moisturizers over the top. It's not a contraindication for using steroids. The fourth common misconception that topical steroid thins the skin. I guess this isn't a misconception. It's a rare side effect of excessive steroid use. The argument here is that the risks of this happening are very low if steroids are used appropriately, and the bigger risk is undertreating eczema and having chronic changes of thickening of the skin that are much harder to treat. So I guess don't be worried about the side effects of steroids if you're using them appropriately. And the last misconception is the idea that natural treatments are safer than topical steroids. And really the point here is that there are lots of additional fragrances and additives in natural treatments that can themselves be precipitants for eczema, and that can sometimes they can even sensitize kids to particular substances. So that's all I have to say at the moment. Here are some helpful resources that I think are really important. So I think that me and Karen have both referred to the Royal Children's Hospital guidelines, and these are clinical practice guidelines. They're very valuable. There's a particularly good one on eczema, and that has links to eczema treatment plan generator. There's also a dermatology department page from the Royal Children's website that has lots of resources for eczema, including some really good videos about the wet dressings that we talked about, and some printouts on the bleach baths and the amount of each substance to put in. I would also direct you to DermNet New Zealand, which is a great dermatology resource. And then I think the other resources are the community resources, so the Royal Children's Community Eczema Clinic, which is the nurse-led clinic. And as I mentioned, one of these dermatology nurses works at the Western Children's Health Centre in Altona Meadows privately. And she's been very helpful, and she's very happy to kind of be involved in some future GP education sessions as well, actually. The one thing I haven't mentioned there is the health pathways, which I know are very well utilised in primary healthcare, but I think there'll be some good resources on the health pathways as well. So I'm going to leave you with a meme, but I'm very happy to answer any questions if there are any. Thank you.
Thanks, Dan. We do have a couple of questions that have come in, so we'll just ask those in a second. So just a reminder, if you have any questions, put them in the question box, and we'll make sure we get to those. So first question from Danielle. Once skin thickening occurs, can it be reversed?
It's a good question. Yeah, so I think it can, but it does just require, a prolonged period of effective treatment. And so I guess the concern is that for whatever reason, the skin thickening has occurred. So whether that's been really difficult to treat eczema or non-compliance with treatment, it's important to try and, I guess, ascertain whether the family or the child can maintain the compliance required. But it can be improved. It just takes quite a long time.
And just a reminder as well, sorry, you can have questions for Karen's topics as well if you have thought of any of those in the meantime. And a question from Sophie. In kids with darker skin, they can get some post-inflammatory hypopigmentation when the eczema is treated. What can we say to reassure parents about this?
That's a really good question. I think it's hard to reassure parents that depigmentation can certainly last for some time, and I've seen that lasting for quite some time. I don't know if there's much that we can do to, I guess, quicken the recovery. I would have to probably ask a dermatologist, to be honest. Karen, I don't know if you have any additional advice on that question. It is quite pronounced, though.
No, only that it does take a long time to go away. So yeah, just making sure they are aware of that.
One thing I would say, there's a great resource on Don't Forget the Bubbles currently, which is looking at identifying dermatological conditions in children, and adults with pigmented skin, and so that's kind of an acknowledgement that a lot of these skin rashes look quite different depending on the pigmentation of your skin, and so there's a great kind of educational resource going on about helping to identify these things earlier, and essentially so we can treat them appropriately and avoid, I guess, some of these complications.
Great. And one more question. You mentioned about natural treatments could be actually quite problematic. Are there any particular ones that you're particularly concerned with that we should be aware of?
None specifically. The one that often comes up is olive oil, and speaking to the eczema nurse, they're very anti-olive oil as well. So they're really, what we're trying to do is avoid any additional additives or fragrances that can potentially be worsening the situation rather than making it better. And their attitude as well is that olive oil is not an appropriate thing to put on the skin, even though intuitively it seems like it might not be inappropriate.
Okay. So we haven't had any more questions come through. We actually had a few earlier, but you managed to answer them along the way in your presentation with all your details. So I think that's been pretty helpful. So I think that might be all. We've made some good time tonight. We're pretty close to finishing time, so we've probably done it well. But yeah, thank you so much for your time tonight, both Dan and Karen. It's a really informative session, and we've certainly got some good comments and good feedback already. And I just wanted to, I guess, reiterate, if you missed the start of the session, that this is part 2 of the 3-part series with Werribee Mercy in the paediatric space, and we've got the ADHD and ASD session that was run in July that's recorded, so you can access that if you still want to look at that one. And the next one's in September, looking at more gastrointestinal sort of area in the PED space. So we'll let you know when that's available to register for. And maybe just we thought it'd be good to mention that we're actually running some education, another series with the National Asthma Council in the coming months, beginning September, just to follow on from some of the stuff that Karen presented, not specifically in the paediatric space, but the Asthma Update 2020, that will cover a little bit of the COVID stuff. Asthma in spring, so looking at the allergic asthma and thunderstorm asthma, and asthma medication and devices, which again will extend on a little bit with what Karen was covering in some of her presentation. So that might be good to keep an eye out for if this is a particular area of interest for you. But again, thank you so much, Dan and Karen, for your time tonight, and thank you for joining us, everybody that's dialed in. As I said, we'll send you an email with a copy of the slides, I believe. So all those great resources that were suggested there, you'll have those listed, and we'll have that evaluation survey for you. But I think that's it. Everyone can enjoy the rest of their night and hopefully have a restful night ready for the rest of the busy week. And we'll hopefully see you next month for the 3rd part of the series. So thank you.